psychiatrist. So Dr. Lawson is really one of America's treasures. He has contributed so much to healthcare. He is currently professor of psychiatry, behavioral sciences at George Washington University School of Medicine, adjunct professor of psychiatry, University of Maryland School of Medicine, emeritus professor of psychiatry, Dell Medical School, University of Texas, and emeritus professor and formerly chair of psychiatry and behavioral sciences at Howard University. He's also that's where he's taught. He's been educated everywhere. He got his PhD in psychology at the University of New Hampshire, his MD from University of Chicago, did his residency at Stanford, fellowship at the National Institute of Mental Health. He's held faculty positions all over the country, University of Illinois, University of California at Irvine, Vanderbilt, Arkansas, Howard, many senior positions, other places, received many national recognitions, president of the DC chapter of Mental Health America. And one of the ones I'm sure he's probably most proud of is having received the National Alliance for the Mentally Ill Exemplary Psychiatrist Award, which means that the people that we take care of as psychiatrists think he's pretty good. So when you're being honored by your peers and honored by your patients, that's saying a lot. One of the ones I wanted to jump out and say was he received the Outstanding Psychologist Award from the he received the Gene Spurlock Award from the American Psychiatric Association. Anyone who's been connected to psychiatry and connected to health in America recognizes Gene Spurlock as one of our champions over the many years. I don't know where he finds the time, but he has authored over 200 publications. He's been the former editor-in-chief of the Journal of the National Medical Association and just continues to make amazing contributions on the federal government side, on the industry side, and on the foundation side, receiving funding to do a lot of work. So it is with great honor. Oh, and he also hosts a mean barbecue out on his back deck. So it's with great pleasure that I introduce to the Black Health Trust again, because he's worked with us before. He's also worked with us contributing to the Long COVID International Symposium that was done several months ago. It's an honor to welcome back to the Black Health Trust to talk to us about COVID's impact on brain and behavior. A bad brother, Dr. William B. Lawson. Dr. Lawson, please take it away.
Thank you, sir, and always appreciate you the honors you give, and I hopefully get the chance to go down a long list of honors that you've accumulated over the years as well. So I'm just going to do this for this share screen. And not sharing. Oops. Getting a little technical because I don't see what I want to see.
I have your slides, Dr. Lawson. If I'm able to share screen, maybe I can pull them up. So go ahead, give it another shot. And let's see.
That I'm seeing aren't the right ones. So yeah, you can pop them up there.
All right, let me see if I can do that.
And this is a new computer for me, so I apologize.
Okay. Okay, I'm not being allowed to share screen over here, Simon. I don't know if you can either pull the slides up or let me.
You have co-host permissions. You can share. I don't have any slides numbers sent to me.
Okay, got it.
Yeah,
Then,
Max.
all right. Is everyone able to see my screen?
Not yet.
No, not yet. Okay.
Oops. Yeah, I'm not getting my screen for some reason.
All right. How about now?
Yes.
Oh,
Okay.
yeah, got it.
Okay, good. Let me do, and
I'll put it on.
And still able to see it?
Yep.
Okay.
That's
Very good.
Yeah,
Okay.
let's see, my new computer does what it's supposed to do.
Okay.
Again, I'm going to talk about brain behavior in terms of, whoops, show. Oh, okay. I can't see to move the slides, but that's okay.
Okay, I can. Can you all see the slides on my screen?
Yes. Oh, yeah.
Okay, so Dr. Lawson, you just tell me next, and I'll go on to the next one.
Okay. Next. And what we're going to talk about, of course, is a novel new coronavirus recognized 2018. Probably get more up-to-date data in the near future. There are now over 292 million cases worldwide, 75 million in the US, 5.7 million deaths, and over 900,000 deaths in the United States. Next one. So the good news is the right masking and distancing seems to prevent the spread of this disease. Hit it again. And we now have vaccines and oral medication approved by the FDA that are available that can prevent hospitalization and death. Next one. But it's easily spread. The Omicron variant has changed the story, far more easily spread than the Delta variants. Debatable about whether or not it's less lethal, and there have been some of these fatalities associated with it. And there may be other variants in the future. Mortality rates remain high. This disease we're recognizing affects most organ systems, and we're now appreciating, as Dr. Walks mentioned, discussion we had earlier about the long haul syndrome, in which we see long-term disability. Next one. And in underrepresented minorities, unfortunately, African Americans and other groups are less likely to be vaccinated, tend to be sicker when seeking treatment, more likely to be hospitalized, and have a higher mortality rate. Next one. Moreover, the death rates have sharply risen, and for non-Hispanic Black folks, the highest of any racial and ethnic group. Next one. So such outcomes is consistent with other diseases with known factors that impact people of color, including the fact that comorbidity is associated with increased death and hospitalization, lack of access to care, and structural racism in a variety of areas. And I might add, this is not just true for physical disorders, but for mental disorders as well. The next one just shows you that this is not new. There was an influenza pandemic in 1918 that was caused by an H1N1 virus. Estimated that a third of the world's population became affected. Number of deaths was at least 50 million. No protection against infection, no antibiotics, and the only interventions were non-pharmacological interventions such as isolation, quarantine, good personal hygiene, use of disinfectants, and limitations of public gatherings, which were applied very unevenly. Some of the political and other issues that's arisen recently, unfortunately, also happened then as well. Next one. And I just want to mention that at the same time, there was another epidemic, encephalitis lethargica of Economos disease, which is unlike the coronavirus, affected children heavily, but it also led to bizarre changes in character and personality. It left sequelae for decades in the forms of Parkinsonism. And unlike the coronavirus, it had a high mortality of around 20%. It involved a number of systems, but prominent was severe depression, mania, catatonia, and psychosis. And this was when we recognized as one of the first pandemic involving the central nervous system. Next one. Now, what was noted again was that those two pandemics had mental disorder sequelae. The mental disorders attributed to influenza increased in the 6 years following the pandemic. Influenza death rates 19, 18, and 20 were significantly and positively related to suicide. And there was an increase in neurological disease, and there's controversy that some folks think that it also led to an increase in the risk of schizophrenia as well. Next one. So what are some of the neurological manifestations of COVID? Polyneuropathy, myopathy, large arterial ischemic stroke, and anosmia, as well as ageusia. So smell dysfunction, taste dysfunction, important in disorder and showing the involvement of the central nervous system. There are also complications in the hypothalamic and cortical neurons. Next one. So infection of the nervous system is now recognized, and that may also be tied in with dysregulation of cytokine activation, which leads to cell-mediated inflammation. Also, some autoimmune mediated mechanisms may be involved, as well as hypoxemia, thrombotic neuronal injury, and also there's hematonogous spread of this disease throughout much of the body. Next one. So what do we see? We see altered mental status, delirium, associated agitation, dysfunction, executive dysfunction. Most of these are seen in folks in the ICU, also delirium and frank catatonia. Next one. And what we're appreciating, as we discussed in the long haul syndrome, is the long-term effects. We found loss of smell can be persistent in some individuals, although in most it does resolve. Delirium and increased risk of strokes. There are also long-term issues such as myogenic encephalomyelitis, chronic fatigue syndrome. Looks like the standard chronic fatigue syndrome, Guillain-Barré syndrome, and additional effects that are triggered by the virus infection of epithelial cells and the cardiovascular system, probably through the immune system and inflammation. Next one. And there are several papers that's come out, including one by Baldrini, which is a very interesting one, in which it proposed some of the mechanisms that account for some of the CNS effects. And part of their interest is generated by the follow-ups conducted in Germany and the United Kingdom, which found 20% to 70% of post-COVID patients had persistent symptoms, neurological symptoms, long after respiratory symptoms have resolved. So it suggests that, and this is something we need to be aware of, may have persisting evidence of brain involvement long after the acute illnesses, long after the respiratory problems, long after the other peripheral effects of the brain. Next one. So what are these? Well, the main ones that we're concerned about as prominent is the cognitive and attention deficits on the brain fog. It's not like the standard attentional deficit syndrome. People report of problems in terms of derealization, perceptual problems, problems in terms of focusing and attention. And then we're also seeing new onset. People never before had anxiety or depression are now developing. There have been reported cases of psychosis, seizures, and as in the 1918 epidemic, increased risk of suicide. So the pathophysiology is being investigated, but the problems of smell, nausea, and vomiting shows that there's probably a direct invasion of the brain and the CNS vasculature. And also due to neuroinflammation and hypoxic injury due to interruption of blood flow in the brain, as well as involvement in the autonomic nervous system, which may contribute to the anxiety symptoms. Next one. And what's been noted that in 2020, there were increased elevated adverse mental health conditions associated. Young adults, racial and ethnic minorities, interestingly, essential workers, unpaid health caregivers report having experienced disproportionately worse mental health outcomes, increased substance abuse, it's a persisting problem, and also elevated suicidal ideation. Next one. Here's a recent finding in the Lancet report, 32% of young adults experienced depressive symptoms compared to 27.8% in the months preceding the pandemic and 8.5% before the pandemic. So depression rates didn't decrease over time as the pandemic spread, they went up. And predictors, not surprising, the low household income, not being married, and having experienced multiple pandemic-related stressors. So this is an important finding, suggests that these effects may be accumulated over time. Next one. So what kind of psychiatric conditions may be worsened? Well, pretty much everyone that we know of: bipolar, major depression, panic depression, generalized anxiety disorder, post-traumatic stress disorder. Those that have of us that have large practices have noted that the pandemic has worsened many of these conditions, including, interesting, obsessive compulsive disorder and some disorders of cognition. Not only do they seem to worsen the symptoms, but they worsen the ability of folks with these disorders to cope, even when their active symptoms are resolved. So there's a psychological impact. Individuals have challenges that are stressful, cause depression, anxiety, and with many of us, especially treating individuals that had to go on a ventilator, being frank post-traumatic stress disorder. Public actions that are necessary to prevent the spread, including social distancing, not surprisingly, leads to isolation, loneliness, which can also increase despondency, stress, and anxiety.
Somebody needs to mute.
So the psychological impact also is predictable since many folks end up isolating themselves. There's a lack of community involvement. Many folks who thought they had relatively limited social lives found that in this situation, the community involvement often was a key part of their life. When it's gone, it's very distressing. They're limited recreational outlets. Again, these are much worse in many of our African American communities, which unfortunately many times housing is in place where there are limited recreational spots to participate in, and this worsens that. And folks don't have the ability to use public transportation to get to sites that may provide recreational outlets. And then there's breakdown in terms of social communication. Some of our usual institutions that provide those, the church, the barbershop, the beauty parlor, just aren't available. Next one. Next one. And just want to note quickly on depression, not surprisingly is there, and just want to go quickly over the symptoms. You don't need to have sadness to be severely depressed. And African Americans historically have not expressed sadness as a sign of depression. And there's also a loss of interest in daily activities, weight loss or gain, and people sometimes gain weight from the isolation of the virus because they're not able to get out, excessive sleeping because of less going on, or insomnia, lack of energy, feelings of worthlessness, a lot of guilt. What we're seeing a lot of survivor syndrome is people lose friends, family members, and then ask themselves, why were they spared when this is happening to other people? And then, of course, there's lots of thoughts of death or suicide equivalents. That is single vehicle auto accidents, for example, or excessive use of drugs and potentially lethal. Next one. And anxiety. I've seen a lot of phobia. Phobia is not too surprising. Folks are not only develop agoraphobia, different problems in terms of becoming anxious when they're in large gatherings of crowds, but many folks develop phobias towards places that they usually derive pleasure in going, because they're now associated as potentially a place that they can get infected. Panic attacks, seen quite a bit. Had several patients who've shown up and gone to the emergency room, thinking they were having a heart attack, but having panic attacks for the first time and literally didn't know what it is. And there's good old generalized anxiety, ongoing feelings of discomfort that is persisting, no obvious cause, and some obsessive compulsiveness. The tendency to make sure that you're completely germ-free. See folks making sure that the doorknobs are clean, the house is clean, everything. There's a tendency towards this kind of behavior. Fears about the virus certainly contribute. And yet many of these problems just aren't recognized or treated in the African-American community. I think I reported before that we found it in our primary care clinics in Howard and Harriet. 17% of the people who had these disorders were not referred for psychiatric help or were treated. So these kinds of conditions exist in our community, but they are often ignored or disregarded, saying that there are other more important things that folks need to worry about. Yet in this case, in the context of the coronavirus, they can be disabling. Next one. So the consequences, we've seen that suicide, the life expectancy rate dropped in the US, probably because of drug overdose and suicide. Suicide rates for Black children have now increased. We just again recognize that up until recently, it was thought that Black people did not commit suicide, although I remind folks about Gloria Island and the high suicide rate on the slave ships. Now again, recognize suicide exists in the Black community. It is a major problem. Sometimes the best interventions can be when the person first recognizes it, and you can get the person in that ambivalent period to take other kinds of actions. Next one. So misdiagnosis is common for mental health, very common for African Americans. Many times certain disorders such as bipolar disorder, it's 5 to 10 years of active symptoms before a person is actually treated. So what we find is treatment is delayed or in many cases refused because of the idea of the stigma associated with mental disorder. You don't want to be recognized as someone who's gone crazy. You don't want to be recognized as someone who needs to involve in the mental health system. There's still a feeling that mental disorders are a sign of weakness or a sign that the family is dysfunctional. And unfortunately, we have a number of new treatments in the last couple of years, last decade, but they are viewed with suspicion by folks in our community. And people are much more comfortable seeking their own treatment from drugs of abuse. Next one. So this is just showing you Oxycodone. It's going to be very popular because some of us have pain, and unfortunately, many folks see pain and depression often as the same thing and try to attack feelings of anxiety and depression with pain medication. Next one. Or they, because of the cost of drugs, sometimes, especially if folks get addicted, they go out and seek it on the street, where you can very easily get drug dealers to give free samples to pretty much anyone. And this is not a problem of poor or African Americans, problem of the country. And at one point, the African Americans were actually underrepresented in terms of people dying from drug overdose. Next one. So in 2020, the overdose just exploded. The availability of fentanyl and other synthetic opiates probably contributed, but it also paralleled the development of the pandemic and the spread of the coronavirus. So there is a relationship between seeking treatment that can be provided by opioids and trying to cope with stress and pain with the coronavirus. Next one. Good news, treatment works for substance abuse. Next one. Next one. But, and unfortunately, African Americans are less likely to get treatments such as medication-assisted therapy, African American providers, less likely to get the agents such as buprenorphine made available. African Americans report more side effects with the old antidepressants, less likely to get antidepressants in the first place, and far less likely to get the newer antidepressants, which have fewer side effects. And I didn't say anything about psychotherapy, but the reality is that treatment with psychotherapy won't for to be the African American individuals who are born again. We're now finding more and more people are seeking psychotherapy, but unfortunately they can't get it, often because of evidence-based psychotherapy may not be available for community mental health centers, and may not have, and folks may not be able to have the support and insurance to be able to get it from private providers. Next one. Then there's the whole issue of day-to-day management in terms of the coronavirus. One is we recognize that African Americans are much more likely to be in jobs in which they are the essential workers and cannot take off. So the pandemic risk is especially impactful for them. African Americans are overrepresented in terms of the correctional population. And the whole issue about whether or not the community wants to provide resources and help for those that are in prison. There's lack of support for childcare and also for homeschooling. We find that there are many African American communities that do not have internet support. I'm pleased to say my hometown, which is a rural town, has recently got an internet set up, but we have many places, many communities in this country, some in the inner city, that simply do not have internet services, and that impacts on homeschooling to a substantial amount. Transportation continues to be a big issue, and we still have in many of our communities food deserts in DC and in Austin. Always amazed that when you map out cities and look where grocery stores are, you often find that they are either absent or very few in African American communities. And this is a real issue when transportation is restricted or when folks are isolated to deal with the pandemic. And then there's health maintenance. We know that chronic disorders such as diabetes, hypertension increases hospitalization and death in terms of the coronavirus and manage them, it can be very effective in improving long-term outcomes. But health maintenance sometimes to suffer because of the issues of transportation, time, and availability of providers other than emergency care or hospital care. Next one. And social cultural issues. Recognize folks end up overcrowding in situations and trying to avoid to practice social distancing. Stigma, lack of trust in terms of public health measures and politicians who have somehow politicized this illness. There's lots of concern about distress regarding vaccinations. I'll come back to that. And ongoing chronic issue of lack of access to healthcare in many African American communities because and few availability of facilities as well as providers, which is a long-term issue that the Black Health Trust has emphasized. Next one. And again, many times because of these communication issues and distancing and other issues, people who may be isolated and depressed never diagnosed. And as a result, interventions are never gotten to people who may even think about frank suicide or needing help and support just to carry out activities of daily living, but are inhibited by depression. Also limited housing, low income, and crime further limit things. Next one. And I just mentioned the isolation issue, bringing people together in closed spaces for long period, having no outlets, no recreational facilities. What we found is finding is there's an increase in spousal abuse and increase in child abuse, substantial increase in child abuse, as well as suicide. Spousal abuse, child abuse, overrepresented in many African American communities, but are not talked about. And unfortunately, help often is unavailable because of lack of services to address these issues, and the alternatives often be to bring in the criminal justice system in which the victims themselves may try to avoid. Next one. Then also, we were very concerned about overdose deaths. There was an increase in overdose deaths among white folks, but then Black folks started overdosing, and that gap, it pretty much disappeared. And Black folks deaths have substantially increased in 2020, continuing in 2021. Next one. And I might also just refer back to the famous Tuskegee study. Those who don't remember, this was a government-sponsored trial that people who had syphilis, Black folks who had syphilis, were recruited to participate in this study and were not treated, were simply observed. That finally to some medical research reforms, president policy, and financial settlement. I think the good news is folks are now more aware that it happened. Bad news is many folks who misinterpret the consequences of that study. Next one. There's an interesting study by Bogart, and what she found is that 97% of African Americans who live with HIV, this is, by the way, also very significant compared to the research we had done among folks who were not living with HIV, in which they endorse at least one mistrust belief, and more than half endorse at least one vaccine or treatment hesitancy belief. People found that social service and healthcare providers are the most trusted sources, but mistrust was associated with vaccine and treatment hesitancy. And also more COVID-19 impacts among these folks as well. So again, medical mistrust, misinformation is a direct effect upon vaccine hesitancy in healthcare among African Americans. Next one. What kind of beliefs are people having? I think we've talked about some of these. I'm hearing new ones all the time. Vaccine will kill you. The vaccine will make you sterile. Vaccine will kill your unborn child. It's not necessary if you have healthy and have a good immune system. It's a mark of the beast. It shows a lack of faith in God. This is a very disturbing one that's that builds on some Christian beliefs that somehow if you had to turn to man to deal with these natural forces, then it somehow shows that you do not trust God. That is white man medicine, despite the fact that there have been a number of African Americans who participated in vaccine development and former slave of Cotton Mather, probably one of the first ones that brought vaccination to the United States. Excellent. So just to emphasize, we try to emphasize folks, the vaccine won't cause you to be magnetized. There's not another book in the Bible that talks about it. And another belief that there's somehow a monitoring devices involved when you get the vaccination. There's just no evidence for that. Next one. So the answers of what we're gonna do is we gotta look at how we're gonna make omelets out of broken eggs, lemonade out of lemons. Gotta be creative. And we must not lose our spiritual foundation. And also must do what we can to develop trust in our providers in terms of African American institutions so that we can provide services. And I will end on that note and open up time for questions.
Thank you so much,
Dr. Lawson. Dr. Maxey, I just wanted to make a comment. Sitting through and listening to Dr. Lawson, I just want to just acknowledge it's a lot to do a presentation like that. And when we have folks come on the Black Health Trust, we've had several folks, just to pick another name, more recently, Dr. Steiner came on with a very well-researched and thought through presentation. And I just want to just say how much we appreciate those outstanding folks being willing to take the time to put something like this together and be willing to come and educate us. It matters a lot. So thank you, Dr. Lawson, and thank you to all the other folks who come on with us every week and really bring a tremendous benefit to everyone who attends. Thank you.
and that is so perfect what you say. And we have a number of our presenters on the call that have presented before, and Dr. Walks is very appropriate in thanking Dr. Lawson for giving of his time. And that was an excellent talk. Even though I want Dr. Walks to lead the discussion, I want to ask something current in terms of psychiatric illnesses. Recently this week, there were 3 NYPD cops who responded to a domestic abuse situation, apparently in Harlem. So I'm presuming that they responded to a Black household, and these respondents seem to be mostly Hispanic cops. But to make a long story short, it resulted in the death of 2 of those cops. And we've heard the talk about sending in social workers, mentally trained people for a domestic situation. How would you prescribe that we look at a domestic situation like that in terms of mental health? I'm presuming it was mental health, but I wonder if you'd comment on that.
Well, I just want to emphasize no evidence that mentally ill people are are more violent than anyone else if they're under treatment and if they're not on drugs. So it may be, I didn't get firsthand look at the data, but they may not have had a diagnosable mental disorder. Simply may have been this is related to the stress of being isolated. May have started out with, and what we find is that in many of these instances, people who know each other, who are involved in an issue that has just gotten out of hand in terms of discourse because nobody there is professionally trained for violence reduction. The District of Columbia has an interesting program which they're actually sending out individuals who are trained in conflict resolution. Austin, Texas had a very nice program in which we had the police trained and recognized to contact mental health providers virtually when they got a call that there was an incident going on. And I was actually asked to become involved in a situation in which we worked with a mental health team, discovered that there was literally no mechanism other than having a SWAT team go in to address some problems. In that case, the patient ended up getting shot, but it led to some changes in terms of how folks would deal with conflict. The facts of the matter is that most of these issues are unfortunately relatively common, and that sometimes it's just sheer luck keeping them from expanding. So I think it's very important to do what we can. Obviously, we should not expect police, except in rare circumstances, to be social workers and to do everything. But what we can do is make sure that those kinds of services, we have the technology now, those kinds of services are available so that we can bring about rapid conflict resolution. So we can make sure that we need to have lethal weapons not immediately available. Not at all clear that locking up guns will reduce homicide, but it certainly does reduce suicide rates. And we also need to do what we can to make sure that drug treatment is available and that support is available for folks so they don't have to turn to street drugs to deal with their problems. And also, so if they do get hooked on these drugs, that they can get off them in a healthy environment.
So, so Dr. Maxey, let me also respond to your question from a slightly different perspective. Some folks know that I was in the military. My job in the military was an ambulance driver, which was a whole lot of fun driving an ambulance with sirens on until you got to the scene. And the most dangerous scenes we ever got to were domestic violence scenes, because you've typically got someone who is injured, and the person that injured them is often somebody who still thinks some kind of way that they still love them. So you can wind up in a situation where more than one person is upset that you're there, that the police are there, and it can lead to a very unexpected escalation of people being uncomfortable and people acting out, even if there's no mental health history. And so along with Dr. Lawson, I want to be very clear that most people that have psychiatric or psychological challenges are not violent. You're not dealing with, everybody who's got a mental health issue is going to be violent. At the same time, domestic disturbances are different in that there's already a lot of stuff that's gone wrong long before either law enforcement or healthcare professionals get there. I also wanted to say that Dr. Hines joined us just as Dr. Lawson was getting ready to start. So lucky for her, she missed my long-winded introduction, but caught all of Dr. Lawson's presentation. Thank
Hello,
you,
Dr.
Dr. Hines, for joining us. Let me say that one of the challenges that Dr. Lawson talked about that is really, for me, a big deal is this whole issue of not having enough access to treatment resources or prevention resources, coupled with hesitancy to allow prevention resources and treatment resources. It's really like the ultimate bad mix. Dr. Lawson, how do we deal with the fact that, particularly in our community, and you mentioned some of this in your talk, but I just wanted you, because you know me, I'm happy to celebrate the problem and talk about how bad it is, but I'm really trying to get to what do we do? So because we've got this really double whammy of we don't have the resources that we need in our communities, and at the same time, we're not willing to utilize the resources. Can you just take us a little bit further down the road and, man, what do we do?
Yeah, I think these are long-term persisting issues that issues that we talked about in terms of talking about structural racism and so forth. If you do a map of most cities around the country and look at the number of hospitals, number of physicians, number of providers, where they are, you'll see this part where it says, this is where all the Black folks live at. No hospitals, no physicians. Recently, they were applauding the fact that we had an increase in the number of Black folks entering into medical school, and it's against a baseline of having no real increase in terms of the number of Black men in medical school since the 1960s. So there's a basic multifactorial effort to deal with this. I was show recently when someone said, what's the best way to deal with violence in the community? I said, well, you got to look back. Back in the 70s, there was a high murder rate in the country, and how we dealt with it was doing a number of different things that everybody considered good, with all the agencies working together. And what we are now benefiting from up until recently is that the murder rate in many of our major cities fell, not because somebody arrested everybody that spit on the sidewalk, not because we had more night basketball, but because we got the folks to get together and work coherently in terms of addressing these, having law enforcement, health providers, politicians work on the same page with the same goals to try to deal with these problems. Any one of these approaches can do a little bit, but they often don't do enough to make anything really meaningful in terms of how to address it. I think, again, Black Health Trust, educating the community, recognizing that these problems are something that our African community can benefit from, the economic, the social benefits of maintaining good health care. Messages that I think all of us recognize needs to be done and has to be done in a sustained way so that we won't end up in this situation again.
If I can ask a question on the issue that you brought up about substance abuse. As you know, even though I'm a nephrologist, I'm doing a lot of primary care medicine. And every day, several times a day, I'll get calls from middle class, upper middle class African Americans. Doc, I've got a cough. And and I said, well, what are you coughing up? Well, nothing, but I'm just coughing, and I'm having a problem sleeping. And I said, and they said, well, I need some cough syrup. I said, well, okay, and I want the kind with the promethazine with codeine in it. I said, well, that'll suppress your cough and suppress you getting up, whatever it is. But they're using that as a sleep medicine or a sedative medicine. And so I really don't like to do that. In addition, a lot of people, including pastors, have knee pain and back pain, and they're on heavy doses of oxycodone or narco, notwithstanding the fact that we know that there's cardiac damage, renal damage, and other forms of damage with that. And these people, they are addicted in many cases, but they're not our normal concept of what an addicted person is. How would we approach those issues?
Well, I think part of it is technology and part of it is education. Educating the public, educating the community about some of these basic health issues. If you go out and have a panic attack, the way to deal with it is not to go to the street corner and actually do say, hey, you got something that'll knock me out because I'm having panic attacks. If you go out and have knee pain, have to recognize that, sure, I can give you something that'll kill the pain now, but it'll make your kidneys fail in about 5 years. So part of this, heavy part of it is educating the public. We, unfortunately or unfortunately, because of our technology, we now have medications that really work in the short term in terms of dealing with these problems. But part of it is having to educate the public that we may need to provide medication plus lifestyle changes plus techniques such as yoga, Tai Chi, and others to be able to deal with these problems. And these other approaches that have developed in other cultures really do work. So the evidence is very strong that we can use some non-medical techniques, or that we can use medications that are not heavily addicting, and that educating people about the risks of taking a drug that's potentially addicting makes a real difference in terms of safety. And it's not only a lifestyle change, but it's a way of how one perceives health. That is, and go into the whole philosophy or the whole throwaway culture thing. You got a problem, take this and it's gone. We have to look at some of these problems and help people to recognize that we have chronic conditions. Your body will, over time, deteriorate unless you do certain things now to keep that from happening. We have ways in which we can bring about and improve quality of life without you running over and getting one pill that's going to solve anything. I've trained in psychopharmacology and spent a lot of time taking people off of medication rather than putting people on. But at the same time, recognize that used appropriately, many problems can be resolved. People can have an excellent quality of life if they do it in a way in which they work with an educated provider and in which they don't recognize these agents as magical agents. They're not magic. They use technology, and to some extent improving, and they're unfortunately working against the system in which the best treatments may not be the cheapest treatments. Unfortunately, the worst treatments are very inexpensive, and so that's an ongoing issue. I think many of who are providers are frequently have to contend with.
So Dr. Lawson, I'm going to ask Dr. Hines to jump in and interact with you a little bit, ask some questions from a little bit different perspective.
Thank you, because I've been itching to get in this conversation. But first, let me acknowledge a comment in the chat from Dr. Sherrod that said, COVID presenting in the pediatric patients could look like headaches and dizziness and may be a predictor for more severe illness requiring hospitalization and resulting in neurological and psychiatric symptoms. So if you wanted to, Dr. Lawson, just if you wanted to comment any further on that.
Yeah, I'm not a child psychiatrist, but I worked with some teenagers and some others who developed these And you're absolutely right. And I think this is where family members need to work with their pediatrician, because they're the ones that may see these symptoms early on and don't know, is this a serious problem? Should I give a home test? What does the home test mean? What in the long run, is there going to be long-term outcomes? Again, remembering this is a disease that did not exist 3 years ago. It just didn't exist. Or if it did, it was way below the radar screen. And so unfortunately, a lot of the research, a lot of the findings, we're going to find the hard way in terms of what the long-term consequences are going to be, and when we should intervene early and when we should intervene later. The bottom line is, if we got the resources to intervene as early as we can, unfortunately, especially in terms of some of the symptoms of the long haul, don't really know what are some of the best treatments to reduce the to prevent some of the long-term consequences. Well, on the other hand, the silver lining is that we may be able to better understand some other diseases that we never really thought about developing preventive techniques, such as attentional deficit disorder, some forms of anxiety, and others. Past, we try to treat them symptomatically, but we now begin to appreciate that there are things we can do early in the courses of these. And my opportunity working with schizophrenia, courses of these that can really change the outcome, so that a person who in the past may have faced a lifetime of illness, we can now make sure that they can have an excellent quality of life later on in life. Just to remind everybody, almost all mental disorders begin in the early teens, late teens. And if there was a way to recognize what can benefit from this intervention, we can really change the course of life for a lot of people.
Thank you. And that kind of is a great segue to, because I have two questions. One is about COVID and the recent information about mild COVID symptoms potentially also being related to neurological side effects. And especially, I think it's an especially important topic to talk about now, because it's the variant that is predominant in this space is not causing a lot of classic, severe respiratory illness. So it may be tempting to, especially for the boosted and the vaccinated, to be a little less vigilant about your COVID protection, because you're thinking, oh, well, I won't get so sick. But just wanted to see if we could speak on that for just a little bit.
Yeah, that's an excellent point. Unfortunately, the kinds of long-term consequences that we're looking at probably we should have a database of neuropsychological assessments to be able to look at this, because simply doing imaging and so forth has not been very, very helpful. What I think is too early now to really get neuropsychological data that's predictive, that's going to know what's going to happen in the long run. This, by the way, not just true for COVID. It's also true. It's always been a question about if someone has attentional deficit disorder, if you give them some stimulant medication, is that going to have some neuropsychological consequences in the long run? The good news is that we find that's not the case. But we had to find it out in the first place before we were able to say that this is something that we can safely address. And by the same token, doing some tasks such as some therapeutic video games that we've developed, for instance, can that change the outcome of someone that has neuropsych problems? And the answer is, we don't know, but we have suggestive evidence that we may be able to make a difference if we interview and do what's what you very well be healthy. And then we get into the whole into the issue about exposing kids to violence on TV and so forth and so on. Is that harmful or is that helpful? And the evidence is that certain kinds of ways in which violence is shown on TV is very harmful, has long-term effects, and other times, on the other hand, other kinds it's just not. So I think those are very, very important questions. They'll get us to start looking at how do we intervene in a positive way, more than we have in the past, when we usually just try to develop an agent medication that we looked at for 3 weeks or 4 weeks, and then make conclusions about whether or not it really benefits people or not. I think now we're going to look at the long-term consequences and long-term benefits of certain interventions that we have that we may have missed before, that could be very helpful.
And then my last question is about, and you touched on this a little bit in your presentation, with regard to people of color being less likely to be treated for their mental health issues, or underdiagnosed or unrecognized. One of the thoughts that I've had on this is about atypical presentations. And you mentioned about how depression doesn't necessarily show up as sadness in people of color, and wondering, are there other atypical presentations for some of these more common mental health things that we can be looking out for in ourselves, as well as, in others? In addition to, I also think another thing is like a lack of dysfunction. Lots of times we're looking for people's lives to fall apart before we think that there's a mental health issue. But I think as people of color, we persevere, right? Like we struggle, and we might be struggling hard, but we persevere. So it may not look the same, on us as it does on others, which also I think may contribute to the underdiagnosing and under treatment parts, as well as the other priorities that you mentioned. So again, just for us to look out for things in others and ourselves, what are some of the more subtle things that we might be looking for? Because I think extreme things are obvious, but.
Well, I think one of the obvious things that we just begin to appreciate is just recognize that sadness is not the only sign of depression, especially for kids. Kids don't express sadness. They go out there and get hyperactive, run about and jump when they're down or when they're facing stress. So just the idea of looking for sadness as an explanation may not be the best approach. But if you look at a change in behavior, change in interest, change in how they're interacting with others, that can be a signal. And the other point is being able to open, live an environment where a person can talk about what's going on. Many times folks feel that talking about what's happening intrapsychically, emotionally, is a sign of weakness. Letting folks know that it is not necessarily a sign of weakness, but maybe a sign that you have something that you can't say, but I can give you the input to do something about it, solve it. And a lot of what you're getting at is that both the American Psychological Association and the American Psychiatric Association begin to recognize that diagnosing has to take into account cultural differences. Even though we speak the same language, doesn't necessarily mean the same thing. That the psychic experiences that are involved could be very, very different. And that's why we need to do more to get diversity in terms of profession, and in terms of our community, and in terms of looking at our policies. And as we have more immigrants in this country, as we recognize that Black folks have an intrapsychic life too. So we need to put out the word. Let's be able to develop other ways of addressing the problems, because they don't respond to psychoanalytical therapy. Doesn't mean that it's fine to do behavioral therapy or intrapsychic family support. And we need to begin to develop a technique called strategic therapy, which was developed to working with folks in the community. So we need to learn from folks who are working in the community with stressors to be able to do that. Yes, there's several algorithms people use. The person has one or two of these, and there must be something wrong with them, and so forth and so on. That's okay. That's what we've done screening techniques. I think the other part of it is to be able to look at the whole person in terms of the environment they're in terms of the circumstances they're in, and see if we can make sense of it by being open to what's going on, and not by trying to figure out how we can get to one single problem, solve it overnight, and then close the door. Many times, the first step, person seeks help, or something happens in terms of their life, maybe most importantly, because it tells us that we need to not have what we call premature closure, but start digging deep in terms of understanding what's going on.
So Dr. Lawson, I again just really want to thank you for the level of scholarship and the level of commitment to be with us today. Dr. Maxey, I wanted to, before we let Dr. Lawson go, there's an old saying, the only reward for a job well done is more work. So I got some more work for Dr. Lawson. Dr. Lawson already shared with us that he's not a child psychiatrist. At the same time, he's seen children running around. And so one of the things that I would like us to do is maybe to come back another time and look at specifically this impact on children. Over the last week, I've been looking at many things being written about how the pandemic has impacted children. And just even if you don't focus on the pandemic, what's been happening with our kids over the last few years? And so much of a huge increase in documented mental health challenges for kids over the last couple of years. One of the ways that kids view themselves in terms of whether I'm doing well or not doing well is school performance. And school performance has been a real challenge for kids for remote learning and for the other reasons that Dr. Lawson mentioned. Gun violence against kids has gone up quite a bit. It's been tough out there for children. And I think getting Dr. Lawson to come back and some other folks that focus on children's mental health to come back and talk to us a little bit about that impact, I think may be huge. I don't know how many of us, or if we mentioned this before, know about the declaration of I'm reading this, the declaration of a national emergency in child and adolescent mental health that was actually published by the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association. These are the academic, intellectual big boys and girls that we look to tell us what's going on with our kids. And when they come together and say there's an emergency going on in children's and adolescents' mental health, I think we need to continue to pay attention to it, because guess what? It's not over. And so I'd like to ask Dr. Lawson to help us to look at more comprehensively what's happening with our children. Why does that matter? We talk a lot about the COVID-19 and the vaccines and vaccine hesitancy and about the numbers of people that are vaccinated and the number. And what's happened when the vaccines became available to our kids is that we've had some parents that, oh man, I can't wait, let me get my kids vaccinated. But the majority of parents do not have their kids fully vaccinated. And we have a lot of challenge around the area of our children and their health. So just want to throw that out there. So Dr. Lawson, can I publicly get you to commit to helping us look at this situation? Sure.
As you know, I'm working on a task force right now that's looking at suicide in African Americans youth with the Congressional Black Caucus. So I think this would fit very well with that initiative. and with other initiatives in which we're trying to get a handle. And here we're in the wealthiest country in the world. DC spends more money per capita than anyone else in terms of children and adolescent care, and our outcomes aren't as good as other settings and other situations. So I think I'd love to be able to get involved with that. You've been in the district's administration and you've seen how it works. So I think this would be a good time to try to look at why is it that we have these resources, but somehow aren't getting the outcomes that we would like to see, and what do we need to do to be able to get better outcomes for kids, and to be able, because I think in the long run that's going to be the real question. What kind of adults will we be producing in the next couple of decades?
Yeah, let me add on
Dr. Maxey, I'm gonna turn this back over to you, but the reason I'm smiling, even though everything that we've been talking about the last several minutes is very serious, is I mentioned something to Dr. Lawson, and I got the same response I get from you and I get from Dr. Hines. Oh yes, I'm working on that. You guys, the level of commitment that we get just amazes me. Dr. Lawson, what do you think about? Oh yeah, I'm already working with the Congressional Black Caucus and we're doing so and so. If I had asked Dr. Hines, I would have gotten, oh yeah, the Maryland Academy of Family Physicians, we're already working on that. And if I asked you, you would give me a similar answer. I just love hanging out with you guys because even though we get a lot of people telling us things that let us know that they're paying attention to what's happening, we also have a lot of people who are toiling in the vineyard and who are actually doing the work. So I'll pass it back over to you, Dr. Maxey.
Well, the real invitation I want is to the barbecue at Dr. Lawson's house when you go next. But I do have another question. One of the big concerns I have is with this long haul syndrome, and in particular with the reported loss of cognitive ability that may go with a clinical or even subclinical infection with the virus. So one, who are the people who are likely to have that, or we don't know that? Is that a big problem as you see it? And is there any, and I know I'm asking you questions we may not have the answer to, is there any way to treat people for long haul syndrome? And you made one mistake. You mentioned that you studied pharmacology. And I know that people are doing polypharmacy. They're taking everything in the cabinet for both COVID and long haul, and I'm afraid they're going to poison themselves. So react to some of that.
Yeah, you're absolutely correct. And unfortunately, because it looks so similar to PTSD and to attentional deficit, it was seen that the same treatments that work for them will work for that as well. Those are two very different problems to treat. And unfortunately, it took a while to develop enough of treatments that will give even 50% improvement. And what I've seen, and I've checked the literature, and other people finding the same thing. Many of the approaches and agents that were used for PTSD and attentional deficit, that don't seem to work as well for long haul. Not to say that something's not going to work. It's just that I think the fact that folks are looking at it systematically. The first part to recognize it exists took us a long time to recognize that there was such thing as PTSD. It took us a long time to recognize that attentional deficit could be treated. I think the same thing is going to happen in long haul. We're going to have to get in the trenches and look at a variety of approaches to see if we can make a difference. Just put a piece of one approach I'm using now with Dr. Woody and Howard with using odorants to see if we can improve outcome in terms of addictions and dementia, which is a novel approach so we find is scientifically based because we can actually see changes in the brain. I don't know if that's going to be the solution, but I think that we now have some tools that I think are well worth investigate it and see if we can get good results. One of the arguments that's been made about not using vaccine is they rushed it. They rushed it. Well, let's see what we can do for a long haul. But it's not the question of rushing. It's a question of doing it systematically, not basing it on folks jumping out and said I saw this on TV or the politician says this is wonderful, but systematically doing solid research to make sure that we're going to get the kind of results that we want to get to improve quality of life.
No, I certainly thank you. I hope you can stick around for a few moments as we answer some of the questions that our listening audience may have. And I wanted to go to Dr. Walks and Dr. Hines and you about some of the things that we need to tell people that are in the guidelines of CDC in terms of vaccine mandates, masking and whatnot, and diet. If we can address some of those, for example, among the frequently asked questions, if you've gotten tested positive for COVID, what type of testing is recommended? What's the difference in a PCR test and the difference in an antigen test or rapid test? And what should you do if you have a positive test? And let's discuss that for a few moments. And the real question that people have asked me a lot, so I've had COVID and I survived it. Do I still need to get a vaccine? I'm wondering if we could address that as a group.
So Dr. Maxey, let me start off. I'll get to your question. One of the questions in the chat that has come up is about Dr. Lawson mentioned that there was a higher incidence of stroke can be caused by COVID-19 infection. And then the question in the chat, I wasn't really quite clear about it. I think that someone was raising a question about an increased risk of stroke from the vaccine and from COVID. I think we've had a couple of different times where there have been some increases in potential side effects from the vaccine. And I think the answer that I would give, and please, Dr. Hines, jump in and correct me if I'm wrong, because you know I'm a psychiatrist. I'm not a family practice doc like you. So when we start talking about strokes, we're getting a little bit out of my depth. But the risk of stroke or many other challenges from getting COVID-19 is way far and away a bigger risk than having something like that from the vaccine. I think last week we had Dr. Ellis, I think it was, Dr. Maxey?
Dr. Estes.
Dr. Estes that was on last week, who really could have just been a photograph for all of the things that Dr. Lawson talked about that could happen to an individual who gets COVID-19. It was just a heartbreaking report to hear from this person that was absolutely super duper functional and was absolutely devastated, not only physically, but psychologically from being that sick with COVID-19. So when someone talks about a particular heightened incidence of something from the vaccine, you don't want to get something similar from COVID-19. Maybe Dr. Maxey, you can respond to that.
Well, yes. First of all, we do remember that the COVID-19 virus gains entrance to the body via the ACE2 receptors. And the ACE2 receptors have a number of, I will call them hormones or enzymes that have a great effect on the clotting mechanisms. Thrombotic events are handled through that using the platelets, their adhesiveness, and it can cause strokes very much. A lot of people say, well, I'm afraid if I take the vaccine, I'll get a stroke. but the stroke liability is in the actual virus. In fact, one of our previous guests, who was the medical director or medical examiner of DC, spoke that when he did autopsies on people dying from COVID, they had clots every place. So you're significantly more likely to have blood clots in your body, strokes from not taking the vaccine, from being exposed to the virus, than you are from taking the vaccine, even though there's been an insignificant number of people who were reported to have a clotting mechanism disorder from some of the vaccines, a very low number of that. So that's how I would address that. So you're more likely to have clotting mechanism strokes, hemorrhage strokes from the virus itself than anything that we use to treat it. Dr. Hines, you want to comment on that?
Yeah, I just wanted to jump in and say, for all of those of you who, and because I also read the question about what can we do to prevent it? There are no recommendations to increase your aspirin, change your Xarelto, change your warfarin, change any of your anticoagulation medicines for those who may already be on things that were meant to prevent stroke. There is no recommendation to change those as a preventative method. There are no recommendations to make any adjustments to any of those things. If you get COVID, you don't need to take extra aspirin and any of those extras for the things that you may already be doing to address prior clots or to prevent clots or those kinds of things. Those things are prescribed in the setting of what we know to be functioning normal cells. And what we're talking about in the state of a disease is things that are not functioning in a normal way. So don't do any of those things without talking to your doctor first.
Yeah, so the thing to prevent it is get the vaccine and don't get COVID.
So Doctor, absolutely. Dr. Maxey, one of the things I actually thought about this earlier this week was because we think about COVID so much in our communities and in this country, and every time we hear from Dr. Kerwin Dawes in Jamaica, I think it helps us broaden our perspectives about this. And Dr. Kerwin Dawes did put something in the chat related to Dr. Lawson's.
Can I interrupt you just a minute?
Yes, sir.
I was waiting to answer that question myself, and I was going to say the cure to that anxiety down there, I need to be invited down there on a first-class flight to give a consultation, and that will take care of all the problems in Jamaica. I haven't been invited yet.
Okay, let me follow up to Dr. Maxey and say, Dr. Kerwin Dawes, I'll fly coach. I'll come down there for coach, save y'all some money. Anyway, Dr. Kerwin Dawes, I was wondering if we could get her unmuted and just give us a little update on what is happening with our friends and brothers and sisters in Jamaica, how things are going for you down there in your leadership role, and maybe address some of the anxiety and other issues that Dr. Lawson raised.
Okay. All right. Wasn't planning to see you guys on the show, but since I did ask a question, we are seeing a lot more domestic violence, a lot more. We are still in a surge, and I think we are seeing a lot of anxiety, a lot of depression, even among our healthcare workers. I get lists every day and people coming every day can't cope. We have actually changed rotations in terms of taking care of COVID patients at the hospital because people are so stressed. In terms of domestic violence, all crime now is up in Jamaica I think for multiple reasons. I think the price of everything has skyrocketed. I know it's gotten higher in the US as well, but much worse in Jamaica where everything is imported. Also, the dollar has devalued. So people are having a much harder time. We are seeing a lot more women being killed by their partners. In fact, they're trying to have a big meeting addressing that. I think it's also because of the isolation and everybody is in these small areas together. I do want to ask something about the strokes though. I am on the COVID ward this month, and a couple of days ago I got, well, actually Yeah, Friday. I got called about a 45-year-old lady who had had COVID probably 14 days before, was mild and recovered with a massive stroke. And when they told me her numbers, I was maneuvering to take her and she died prior to coming. I was wondering, in terms of advice, when you have COVID, we do anticoagulate, but this was a person who actually was mild and actually, as far as I know, didn't have to be admitted for COVID, was actually managed at home, and only risk factor was mild hypertension. How I wanted to know, because I was trying to look at data, how long do, I think Dr. Hines said we don't recommend like aspirin and stuff afterwards. In Jamaica, we have a lot of strokes regularly. Some in most of our treatment here, we are putting people on aspirin as outpatient when they have COVID. And we have been finding, we haven't done any big studies, it seems to lessen the amount of strokes. Now, granted, Jamaica, as Black people with hypertension and diabetes, even in people, because this lady was not, we do see, we have a high number of strokes in general. And as for this lady, it was a thrombotic, she didn't, it wasn't a hemorrhagic stroke, it was a huge thrombotic stroke. Do we have any data on that? Because some of the guys were asking me, should they change the guidelines on when they discharge people now from the ward? This was a transfer from another hospital to us, but they also asked me because we are their referral hospital. Anybody can help? You know, I always ask hard questions with new data.
Well, the data I've seen basically said avoid heparin per se as a no-no in those types of issues. But again, we don't know if the stroke from the data you presented was a result of COVID or a result of cardiovascular disease. Did she had a post?
No, this was Friday, so she wouldn't have had her post yet. She should. I'm not sure if she's going to have it because right now they are not doing most posts on COVID patients, and she would have fallen into having a recent COVID with a recent CT scan. So they're going to probably just, I am guessing, just write the death certificate and saying that this is from a massive stroke. But it was not hemorrhagic because the day they were transferring her to me, they sent me a copy of the report.
And she was not vaccinated?
She was fully vaccinated.
Okay. Is Dr. Gary Dennis on?
Dr. Maxey, let me say this. First of all, Dr. Lisa, thank you so much for talking to us despite that not being your plan this afternoon. I'm always anxious to know what's going on. Dr. Maxey, I'm always comfortable, maybe too comfortable with saying I don't know and I'll get back to you. And if Dr. Dennis doesn't have an immediate answer, Dr. Lisa, we can certainly ask the tremendous team that Dr. Maxey has put together of Black Health Trust experts and get some information back to you. And it is okay, my sister, for you to ask us hard questions. And it's absolutely
I don't know
okay.
either, and I've gotten very comfortable because the other hospital is asking me. I'm head of infection control, and I help to write some of the guidelines.
Right.
So I'm also changing every day how we treat them, how we treat patients according to what I read. So I do ask and I send out, I call people abroad and say, what's your data? And things are changing every day. What we thought was good 6 months ago, data changes. And now we're trying that.
Absolutely.
But I don't know. By the way, both of you are invited anytime. I don't know if we have money to fly you down, but we can make you part of a meeting, so it's totally tax deductible. And Randall,
you know what? I like the way you think. I like the way you think, Doctor.
I can do that anytime. By the way, NMA is in Jamaica in May. So Randall, anybody who wants to come should try and come because I was just told.
Okay, that's reason 1 or 2, I think.
Oh, okay. But I know they're coming to Jamaica in May. At least that was what I heard.
So a couple of
Jump in
things.
for just 1 second.
We are getting close to the end of our time, if we're not already over. Dr. Hines, I know you had something, and then I see Dr. Sherrod has had her hand up for several minutes. Dr. Hines, please.
Mine is really brief. 2 things. One, I don't know the answer to your question, but from the little bit that I've seen, I know that the JAMA had an article that says it's at least 2 months. The median is at least 2 months of increased risk after convalescing after COVID. So I don't know the long, like on the far end, but it's at least 2 months because the median.
So we should be putting them on aspirin right after they come out?
So I can't speak to the treatment regimen specifically, but as far as the duration of time for increased risk of stroke, I can put the article link in the chat.
Thanks.
And then the second thing I just wanted to clarify from what I said earlier, I was not attempting to say that there is no role for aspirin. What I was attempting to say is people don't do home treatments, don't change your home regimens without talking to your doctors first, because sometimes people are tempted to go, oh, I take aspirin because I'm not supposed to have a stroke. Maybe I should take more aspirin. That's what I was trying to get at. Don't do things on your own without your doctor's input. That's what I was trying to say.
Okay.
Very good. Very good. Are there any other questions in the chat, Dr. Walks?
I know that Dr. Sherrod is now unmuted and can go ahead and ask her question. Dr. Maxey, there are a few other questions and comments in the chat, and I think that due to Dr. Lawson's comprehensive presentation, I will blame him. We can be here for another 2 hours. So we're going to have to take some of these under advisement, and when Dr. Lawson comes back, or maybe we can respond to some folks over the course of the week. So let me see if we can just go to Dr. Sherrod briefly.
Yeah, thank you so much. And I want to commend Dr. Lawson on such a great presentation. I wanted to answer several questions. Dr. Maxey asked the question about long COVID and what's being done about that and how do you treat it. And the only information I have on that is that they are using fluvoxamine. And I'm sure Dr. Lawson and probably Dr. Walks understand what that medication is. It has been used in some people, and I don't really know the details of the outcomes. And the other question was concerning the COVID test and what do you do when you test positive? And I think that is a very pertinent question because we're testing more now and people are testing positive and don't know exactly what to do. And actually, we had an update from Dr. Montu Davis from LA County Department of Health Services, and I asked him that question. They're not telling people, they're telling people to isolate and quarantine. If you're positive, you isolate, and then your family, everybody exposed, get quarantined. But there's no mention of treatment. And I just briefly, I had an experience with a relative the past 2 weeks that I wanted to bring up concerning mental health. This is a young man, 30 years old, my grandnephew who texted me that he had a positive COVID test. He's a manager at Home Depot. His temperature was 101, which is of concern to me. And so I actually treated him with an antiviral and an antibiotic. I used Valtrex because one of my primary care physicians had treated 47 patients in the first year of COVID using Valtrex, which is an anti-herpes drug. And she documented the cytokine storm can be aborted with Valtrex. She gave them 1 gram 3 times a day for the first day and repeated the cytokines. She did the cytokines before and then did them 3 days later, and they were all back to normal. So you know that the damage comes from the cytokine storm. So I used that in him within 24 hours. His temperature he was afebrile. He had been 101, and he felt a lot better. So he went back to work in 2 weeks. And I was concerned because I had not seen anybody present with just headaches and dizziness and heavy eyes, he said. No upper respiratory tract signs. And so I called him up and he said, well, why are you bugging me? I'm back at work and I'm well. I said, but how are you doing? He said, you know what, Auntie? My spirit has been zapped. You know, I'm a go-getter. but it has taken a lot out of me. So what I'm hearing is that he has some cognitive dysfunction. He said, and my memory is not as good. So I think this, and I think he may have had the Omicron because the incubation period was short and his temperature went up rapidly. And I had another relative who actually had a seizure. So I think Dr. Maxey is on point in the concern about the cognitive impact of Omicron. I think it's actually targeting the brain, and we're going to be seeing more cognitive effects from it, even though it's supposedly a milder illness. So those are the things I wanted to bring up. But Dr. Maxey, I'm going to research the tests that you brought up, the question about that, because see, there are questions about the PCR. You know, the PCR is not a diagnostic test because it can detect dead DNA. So if you test positive, it could be falsely positive and doesn't mean that you really are going to have symptoms or have the infection. And then the rapid antigen test also has false positives, and they're recommending that if you get a positive with the rapid antigen, that you get the PCR. So that is a big confusion. And you know, the CDC was thinking about discontinuing the PCR test.
Yeah,
so that I can do research on.
And we know that can be positive for weeks to months.
Exactly.
So it's
and that's the problem. That's the problem with that.
So
what we
recommend is that people get 2 rapid tests in a row, maybe separated at most by 1 day, before you say you're negative or positive. And we also recommend that people who get the virus and have a documented case, that they don't just say, well, I've got the virus, I have a good immune system, but after a certain period of time, if they've not had symptoms, it's recommended that they can get the vaccine right away. If they have been symptomatic, they may need to wait, I think it's 60 days to 90 days before they get the vaccine. Is that correct, Dr. Walks?
I'm going to toss that to Dr. Hines, who looked like she was just getting ready to answer.
So currently the CDC is not, are we talking about the initial vaccination or booster? Because currently the recommendations are if you're vaccinated and, for example, you get COVID, but you haven't gotten your booster, there is no recommendation to delay getting your booster. I have to actually reread up on whether or not there's still a delay if you get COVID from getting your original vaccination series. And the last time I looked at that was 3 weeks ago, which might as well have been a year ago. So,
yeah, well, I looked at the guidance this morning, so you can get it right away. And just the other thing that I wanted to mention is that, and I did look at the video you sent me, Dr. Sherrod, that it is very important to get that vaccine. I spoke with one of my mentors yesterday, and he got his second booster. And I'm getting ready to travel, and I'm going to get my second booster. So I've had my 2 regular shots, my Pfizer shots, and then I had the booster. That's 3. And this week I'm going to call Dr. Abraham and twist his arm so I can get my 4th shot. And it has been shown that will raise your immunity, shake things up. There are some other studies out that have shown that taking heterogeneous vaccines may be the next thing mentioned, that as opposed to taking the same vaccine you had before, there may be some validity in shuffling things up and mixing the various RNA vaccines, especially if you've had the J&J vaccine or one of the adenovirus vaccines. So, Dr. Lawson, you have given us a great service. Yes.
Hold on, Dr. Maxey, before you go to Dr. Lawson, let me just as the young people like Dr. Hines would say, let me just pump the brakes for a minute. I heard you say that you're about to get your 4th shot, and you're about to twist Dr. Abraham's arm for your 4th shot. Let me not misquote you. I think it's important for us to let people know that talk with your doctor, like Dr. Maxey is going to talk with Dr. Abraham. He's going to go to Dr. Abraham and request a fourth shot. We don't know if Dr. Abraham is going to allow him to have his arm to be twisted and give him a fourth shot. I think that we really want to focus on what the established concerns and recommendations are. I appreciate Dr. Hines with the lightning fingers being able to look stuff up and read the current guidance right now so that we know exactly what the current best information and the best guidance is. I don't want us to say that the Black Health Trust, and I know Dr. Maxey did not say this, he did not say that everybody listening run to your doctor and demand a fourth shot. That's not what he said. So I just wanted to clarify that we are asking people to follow the established scientific recommendations. And the first one is get your vaccine. If you're eligible, get your booster, and then do all the other stuff. Wear your mask, keep your distance, wash your hands, all of those things. I'm sorry, Dr. Max. I hate to interrupt you. I was just trying to, be careful.
That's okay. You're my psychiatrist, so you're allowed to do that. But I am showing my confidence in the vaccine process that I'm going to be first in line whenever they're available, and that is true. But as we start to close, we're well past our hour and a half. Dr. Lawson, do you have any final words of wisdom?
Well, just to note that the good news is that we're looking at a number of different ways to treat this disorder. Fluvoxamine was found, I actually talked to some other group who saw some evidence that there may be a signal. Trials are going on now. It's an SSRI. There was some evidence that maybe fluoxetine, Prozac may be effective, but it's not showing the same kind of signal as fluvoxamine. So I think you're going to find other products that are going to be effective. The important thing is to make sure that before we get it out there, that we do the trials so that folks don't be taking something that's just not going to be effective.
Dr. Walks, let me go back to something you started a minute ago, and that's on the diet. I've been doing a lot of reading over the past few days, and it is extremely well documented that vitamin D does enhance your immune system through the RAS system. And so I'm going to continue to recommend that people have a good diet, and you include in there, I say prenatal vitamins only because they have all the micronutrients that they need to have, that you have vitamin C, at least 2 grams a day, that you have vitamin D. And there, when Dr. Norris was on, he suggested a 50,000 unit dose per week for 4 weeks. And then you take that down to 2,500 a day, vitamin D after that, and that you might also add a little bit of zinc. But the main thing is you can obtain most of that from eating leafy green vegetables, vegetables of all colors. So we do want to recommend those, and those are common sense recommendations more than necessarily medical recommendation. And in the talk last week, Dr. Salavu showed us how that the Omicron could be picked up tactilely or by touch, because it does have a certain length of time it will remain on surfaces. So when you're exposed to other people and you don't know their status, it's important to wear gloves or do frequent hand washing, etc. And that's very important. And before we get to our co-moderators, Mr. Dorsey, would you speak for 30 seconds on this magic machine you have that can help us in COVID? And I want the one that goes around my neck. You can send it to me. Can he be unmuted?
Good afternoon, everyone. Good afternoon. Good afternoon.
30 seconds.
I am dropping my information in the chat box right now. This is scientific space certified technology that's being used increasingly all over the country to add an extra layer of protection in the face of what we're going through.
Well, thank you so much. And I want my one that I hang around my neck. Dr. Hines, how are you? I'm glad you're here with us. We missed you, and we'd love some words of wisdom.
I just wanted to say that this has been an excellent session, and it's so great to see you all again. I was on a little bit of vacation, but during our discussion about what we're all going to do on the future of COVID and how we're going to do things, some of us were looking a little bit overwhelmed on the camera. And I just wanted to just acknowledge that science is always changing, always it's moving, right? The truths of science are just not stagnant. There are things that I learned in medical school that were truths that are no longer truths now. And in the context of talking about the depression and the anxiety and the weight and the stress of COVID and how to live your lives, and someone else put in the chat, like, these are your golden years and you're supposed to be spending it traveling and seeing your loved ones. And essentially, I'm going to put my own words in here. It feels like COVID is stealing some of that time from you. It's okay to not be okay, right? It's okay to feel overwhelmed, to feel confused, to not know what to do, what's next. You set this future groundwork. Okay, when this happens, then I can go, right? Well, when this happens, then I can go. And unfortunately, that's just not how this particular thing is playing out. But what I will also say to everybody on this call is, we have faced uncertainty before.
Amen.
This is just an uncertain time. We have faith for a reason. And it is
Amen.
for times like this. God was in control yesterday. God will be in control later on today. God is in control now. That's it. You will do as much as you can do, and there will be some things that are not in your control. You can behave as responsibly as you can behave, and then we have to move forward with faith and with trust. That's it.
Amen.
And I'm giving some virtual hugs out there.
Good. I want to go that Alan you went to too. Dr. Walks, I enjoy my repartee with you every Sunday and sometimes in between. What words of wisdom do you have?
I have, the word of wisdom I have is ageusia. Now, that was a word that was in Dr. Lawson's slide, and I want to show of hands. Who knows what that meant? My hand can go up because I just looked it up. It means the loss of taste, which is one of the symptoms of COVID-19. One of the challenges that we have on the Black Health Trust every Sunday is that we have so much intellectual power that comes on with so much good information that I just want to encourage all of us to continue to define the words that we use, because we have a very diverse audience, and to make sure that we have a minute that looks stuff up. Thank you, Dr. Lawson. I learned a new word. I really didn't know that one. So I think, and being honest about what we don't know, that came up earlier today. It is really okay for everyone on this call to not know an answer to something, to be willing to say that, and to be willing to go for help. One of the benefits that we have is that we have folks like Dr. Clark, Michelle Clark put in the chat earlier what fluvoxamine was, and other folks have put information in the chat to help all of us walk along together. And that's my word. We often say that we're all in this together, and we're not always as careful as we need to be to make sure that we're reaching out and holding someone's hand and taking them along. I really want to thank Dr. Lisa Kerman-Dawes for not planning to talk to us, but being willing to talk to us anytime and share with us what's going on. And I want to thank Dr. Hines, because it's nothing like those virtual hugs to help us continue to move along together. It matters a lot that we care what's going on down the street, that we care what's going on in Jamaica, that we care what's going on with all of these faces that we see on a Zoom call. So I just want to echo Dr. Hines's hugs today, Dr. Maxey.
Well, thank you so much. And I appreciate everybody for joining us today. I appreciate very much Simon, who is our technologist, for making the show go. I don't see Pastor Pointer.
I see my sister
You
Brenda
see
Lee
Brenda?
Eager on, and I'm always happy to put her to work.
Okay, well, that is just where we're going in just a moment. Dr. Barbara is out today. She had an event happen in her family, so she's in attendance there. We know that there are others who need and want prayer, and we're sending that to you. We have developed into a bit of a family, a bit of a community, and we do, to echo Ivan's words, care about each other. And we send prayers to Dr. Neighbor Stevens and other families who are on the line. And I'd love to have Miss Brenda Lee Eager. And I have to tell you that I met Brenda when I was a freshman in medical school. That was about 3 years ago. Miss Brenda Lee Eager, would you take us out?
I'd be glad to, but I want to say to Dr. Hines, you helped me more today than you would know. I've just gotten over COVID, and it wasn't as bad as I didn't go to the hospital. I really just had a major headache on the side of my head, and I just got very weak, no coughing, no loss of appetite. But I had taken all my shots, thank God, and my children and grandchildren have experienced COVID, and they've taken all their shots. So everybody is good now. But I must say, it was a little overwhelming this morning. Thank you for the information, but this is what I know. We shall overcome.
Amen.
We shall overcome. We shall overcome someday. Not very far from here. Deep in my heart, I do believe, oh yes I do, that we shall overcome. I know we shall overcome. We shall overcome someday. Oh yes we will. Oh yes we will. Thanks to you, beautiful doctors and beautiful lovers of mankind. God bless you all.
Thank you, Ms. Brenda. Everybody have a blessed day and be safe.
Amen.